Treatments for COPD. Hello and welcome to the next talk in the Breathing Space COPD Empowerment course. Today's talk is going to go over some of the treatments that are available for COPD. This will include treatments that may be offered to you by your GP team and also touch on some of the treatments that can be provided by the hospital respiratory team. Before discussing these, I just want to reinforce the importance of the non-medical treatments that we've discussed in a previous talk. I cannot overemphasize how important stopping smoking is, along with keeping active and attending a pulmonary rehabilitation course. These lifestyle changes alone are likely to have a dramatic impact on improving your symptoms, reducing the frequency of infections, and also slowing down the rate at which your COPD worsens. Alongside these, it is important to ensure that you are taking up the offer of any vaccinations that are offered, as these are important in reducing the frequency and severity of exacerbations, as well as reducing the chances of non-lung related complications. The mainstay of medical treatment for COPD involves the delivery of medication directly into your lungs using devices known as inhalers. There are two main things you need to know about your inhalers, which are when and how to take them. The latter is particularly important, as in order for an inhaler to be effective, it needs to be used correctly. An incorrect technique when using an inhaler results in the medication not reaching the lungs and therefore not working as well. What I would recommend you do when you return home is to have a look at your inhalers and try to determine what type of inhaler you have. There are essentially two types of inhalers, which are known as MDI inhalers and DPI inhalers. MDI stands for metered dose inhaler, while a DPI inhaler stands for dry powdered inhaler. The technique required to correctly use an MDI inhaler is different to that required to use a DPI inhaler. It is quite easy to determine whether you have an MDI or a DPI inhaler. Generally, with an MDI inhaler, you will find that when you press the button on the inhaler to dispense the medication, a fine mist will spray out from the device. You will also find if you shake it, you will usually be able to hear a liquid moving around inside the device. MDI inhalers use a propellant to expel the medication from the device. With a DPI inhaler, you will find that pressing the button on the inhaler does not result in any medication being expelled from the device. Also, if you were to shake this type of inhaler, you would usually hear what sounds like a powder moving around inside. DPI inhalers do not contain a propellant, and it is your breath which replaces this. It is the presence or absence of this propellant that determines the technique required to correctly use your inhaler. So what is the technique for each of these inhalers? With an MDI inhaler, you need to breathe in slowly and gently at a steady rate and as deep as you can until your lungs are full. This differs to the technique of a DPI inhaler, where you need to breathe in strongly and deeply. Because there are many different inhaler devices being used, it would not be feasible in this talk to demonstrate how to use each one. You will, however, have a one-to-one session with our nurse, who will be able to check your inhaler technique and provide individualized feedback. It is important to also point out that those of you with an MDI inhaler may also have been given a spacer device to use. Spacers are particularly important if your inhaler contains a steroid, but they also help to increase the amount of medication that reaches your lungs. To use a spacer, the inhaler is inserted into one end and you breathe in through the opposite end. The medication is then released into the spacer and you are able to breathe in and out through the tube around 4 to 5 times to take the medication into your lungs. When should I take my inhaler? It is important to know when you take the inhaler and to ensure that it is taken at the same time each day and on a regular basis in order for it to be effective in controlling your symptoms. Inhalers can be considered as either a preventer inhaler or a reliever inhaler. Preventer inhalers are designed to be taken on a regular basis, regardless of whether you are struggling with symptoms or not. These are typically taken either once a day or twice a day. Reliever inhalers are typically taken only when you have symptoms. These contain a fast-acting medication that helps to open up your airways and can help to relieve the symptoms of breathlessness, chest tightness, and wheezing. It is therefore important that you are familiar with when to take your medications and ensure that you are consistent at doing so. So how do the medications within the inhalers work? Depending upon the type of inhaler you have, this can contain anywhere between 1 to 3 medications that each work in a different way to help make it easier for you to breathe. In COPD, the two most common drugs are referred to as a LABA and a LAMA medication. These both work by causing the tubes that carry air down to your lungs to open up and to remain open throughout the day. These are typically considered long-acting drugs and will usually last for anywhere between 12 to 24 hours and are taken on a regular daily basis. These two types of drugs can have some side effects, however these are typically mild and will often improve with continued use of the inhaler. Common side effects include tremor, headache, muscle cramps, fast heartbeat, dry mouth or diarrhea. Some people may also have a third medication within their inhaler. This is particularly the case if you are having frequent exacerbations or it is felt that you also have asthma. This medication is a steroid, and as it is in an inhaler, is often referred to as an inhaled corticosteroid. This medication works slightly differently to the other two medications in that it works directly on the tubes in the lungs to reduce inflammation. As previously mentioned, it is this inflammation that causes the airways to swell up and become narrow. So by trying to settle this down, it can help to improve your symptoms. As mentioned at the start of this talk, inhalers are the mainstay of medical treatment. However, for some people, they may also be prescribed tablets to help with their symptoms. One of the commonest tablet-based medications that might be prescribed by your GP is a tablet that helps you to expectorate sputum. This group of medication is called a mucolytic, and it helps to break down the mucus that is formed as a result of the damage to your lungs. This may therefore be prescribed if you are coughing up a lot of sputum or feel you are having difficulty clearing sputum from your chest. It does not work for everybody, and we would recommend trialling it for around a month. If after this time it has not been very effective, it can be stopped. However, if you have received benefit from it, then it may be carried on longer term, although the dose would often then be reduced. If despite being on an inhaler containing all of the three medications and you are still continuing to experience frequent exacerbations, you have stopped smoking and have attended a pulmonary rehabilitation course, then you may be referred to the hospital for consideration of some more specialist medication. There are typically two options that might be considered by the hospital. The first of these is a long-term antibiotic. Typically the one used is called azithromycin and is usually taken 3 times a week. This will be considered as a treatment for people with COPD who have had more than 3 exacerbations requiring steroid tablets and 1 exacerbation that has required hospital admission within the past year. It is important that this medication is started by a respiratory consultant, as there are a number of other conditions that need to be excluded first, and there can be side effects associated with long-term use that need to be monitored. Another alternative medication that can be used by the respiratory consultant is called roflumilast. This helps to reduce inflammation in the lungs and may be considered as an alternative to azithromycin. There are quite strict criteria for using this medication, and if you continue to smoke, have not attended a pulmonary rehabilitation course, then you may not be eligible for it until these 2 issues have been addressed. Lung reduction surgery is another option that can be considered for people who are struggling with breathlessness and have quite severe emphysema. This procedure helps to reduce the amount of air that is trapped in the lungs and can therefore reduce the sensations of breathlessness. It is only suitable for a minority of people with COPD, approximately 1 to 2%. And again, there are strict eligibility criteria, which include having attended pulmonary rehabilitation and having stopped smoking. The way this procedure is done may involve surgery to remove the damaged part of the lung, or in some cases can involve putting valves into the tubes that prevent air entering certain parts of the lung. The overall result of both of these procedures is that less air is trapped in the lungs, resulting in a reduction in breathlessness. One of the things I'm often asked by people suffering with COPD is whether oxygen therapy will help with breathlessness. Most people living with COPD do not require oxygen, as its use would not help with these feelings of breathlessness. As previously mentioned, breathlessness associated with COPD is due to air being trapped in the lungs, and as a result, oxygen therapy will not improve this. There are, however, a small number of people whose oxygen levels are low, and it is in these people where the use of oxygen can improve symptoms. There are primarily 2 different kinds of oxygen therapy used for people with COPD. The first is called long-term oxygen therapy, where it is recommended that you use the oxygen for at least 15 hours a day. This is typically used for people whose oxygen saturation levels when resting are below 92%. Another type of oxygen therapy that is used is referred to as ambulatory oxygen therapy. This is where oxygen is provided to use when you are mobile and is typically given to people whose oxygen levels when they are walking drop below 92% but are normal when they are resting. If it is felt that you would benefit from oxygen, then you would typically be referred to an oxygen nurse who works at the hospital where they will undertake further tests. These tests may include taking a sample of blood to measure the oxygen levels directly and also undertake a walking test with and without oxygen to see if this helps. If it is felt that you would benefit from having oxygen at home, the nurse will prescribe this and arrange for it to be delivered. It is important to highlight that if you currently smoke, then you would not be eligible for home oxygen due to the fire risks associated with this. Also, before it is prescribed, a full risk assessment will need to be undertaken with somebody visiting your home to assess for any risks such as open fires or gas cookers. I hope you have found this overview of treatments for COPD useful, and we will now take any questions.